Alcohol, Ethanol, and Methanol by Dr. A. Ramya, Assistant Professor, Department of Pharmacology, SPS, Vistas. Alcohols are actually hydroxyl derivatives of aliphatic hydrocarbons. There are three categories of alcohols. 1. Monohydroxy alcohols. They have only one hydroxyl, OH group. For example, ethanol, methanol, isopropanol, etc. 2. Dihydroxy alcohols. They possess two hydroxyl groups and are referred to as glycols, for example, ethylene glycol, propylene glycol, etc. 3. Trihydroxy alcohols. They are not really alcohols, but only derivatives, for example, propane derivative glycerol or glycerine. Ethanol. Synonyms: ethyl alcohol, grain alcohol. Physical appearance: clear, colorless liquid with a faint odor and sweetish burning taste. It is both water-soluble and liquid-soluble. Ethanol uses. Beverages. Popular alcoholic beverage include beer, wine, whiskey, gin, brandy, rum, and vodka. In addition, there are several indigenous preparations peculiar to particular regions. For example, arrack, toddy, and feni in India, tequila in Mexico, sake in Japan, eau de vie or fruit brandy in France, etc. Solvent for aftershaves, colognes, mouthwashes, and perfumes. The alcohol content: beverage light beer, lager and pilsner, heavy beer, ale and stout, natural wine, cider, fortified wine, sherry and port, whiskey, gin, and brandy rum liqueurs, for example, cognac, creme de menthe, schnapps, etc. Ethanol content: percentage by volume: 4 to 6, 6 to 8, 2 to 3, 10 to 20, 40 to 45, 40 to 50, 17 to 50 ethanol content in alcoholic beverages. Medicinal uses: several antihistaminic, decongestant, multivitamin, and cough syrups contain varying percentage of alcohol, 2 to 25%. Ethanol has been popular in the past as an antiseptic. Surgical spirit used even today is mostly ethanol with a small quantity of methanol, 90 to 95% and 5 to 10% respectively, along with traces of castor oil and methyl salicylate. Ethanol sponging is an effective remedy for hyperthermia. Injection of dehydrated alcohol. Absolute alcohol in close proximity of nerves or sympathetic ganglia is said to be effective for the relief of long-lasting pain in conditions such as trigeminal neuralgia. Antidote for methanol and ethylene glycol. Preservative rectified spirit, 90 to 95% ethanol, is used as a preservative for viscera for chemical analysis. Fuel. Ethanol is used to extract nucleic acids from whole tissue or tissue culture in virtually all biotechnology processes. Usual fatal dose: 1 pint, approximately 550 milliliters, or quart, 2 pints or approximately 1,100 milliliters of a strong distilled spirit such as whiskey taken in a short span of time can be lethal. The usual fatal dose corresponds to approximately 6 grams of ethanol kg body weight, adult, 3 g/kg, child. In terms of blood alcohol, a level in excess of 400 to 500 mg, 100 ml, is usually considered to be lethal. However, there is a great deal of controversy regarding this, since there are case reports of individuals succumbing to much lower blood alcohol concentration, BAC, while there have been reports of survival even with a BAC of over 1,000 milligrams. Toxicokinetics of ethanol. Ethanol is toxic by oral, inhalation, subcutaneous, intravenous, intraarterial, intraperitoneal, and dermal routes. Following oral administration, ethanol is rapidly absorbed from the stomach, 20%, and small intestine, 80%. MAC in blood is reached in 30 to 90 minutes following the last drink. Following an equivalent dose of ethanol, women achieve a higher blood alcohol level than do men as a result of decreased gastric alcohol dehydrogenase activity. More than 90% of ethanol ingested is metabolized in the body, and only 5 to 10% is excreted unchanged by the kidneys, lungs, and sweat. Excretion of ethanol by the lungs obeys Henry's law. Henry's law. It is the ratio between the concentration of ethanol in the alveolar air and the blood is constant. This alveolar air blood constant, 1/2100, forms the basis for reliably estimating blood alcohol concentration by breath analysis. Alcohol metabolism. Metabolism of alcohol is accomplished through three pathways in the liver. 1. Alcohol dehydrogenase. Pathway 2. Microsomal ethanol oxidizing system, EOS, located on the endoplasmic reticulum. 3. Peroxidase-catalase system in the hepatic peroxisms. Ethanol gets converted into acetaldehyde in the presence of alcohol dehydrogenase, ADH, and get converted into acetate in the presence of aldehyde dehydrogenase, ALDH, to give acetyl-CoA in the presence of acetyl-CoA ligase, ACSL ethanol metabolism rate. In adults, average rate of ethanol metabolism is 100 to 125 mg/kg/HR in occasional drinkers and up to 175 mg/kg/HR in habitual drinkers. The blood alcohol level generally falls at a rate of 15 to 20 ml/d 100 ml/LHR. This may be higher, up to 30 ml/d 100 ml/LHR in chronic alcoholics. Mechanism of action. Ethanol acts by enhancing gamma-aminobutyric acid, GABA, GABAergic function through interaction with GABA-A receptors and associated chloride ion channels. However, some investigators are not convinced by this theory. The second theory, which appears to be more convincing, has to do with N-methyl D-aspartate, N and DA, ligand-gated glutamate receptors. N and DA receptors mediate neurotoxicity by increasing permeability to calcium and regulate neuronal long-term potentiation. Studies demonstrate that in the acute form of ethanol use, NMDA receptor function is inhibited, while chronic ethanol use results in upregulation of NMDA receptors. Pharmacological actions. CVS. The effects are dependent on dose. Small doses produce only cutaneous and gastric vasodilatation. Moderate doses. Tachycardia, mild rise in blood pressure. Large doses. Direct myocardial and vasomotor center depression, and there is fall in BP. Blood. Raise HDL cholesterol level and decrease LDL oxidation. Body temperature. Alcohol is reputed to combat cold. High doses depress temperature regulating center. GIE. Stimulates digestive enzyme, inhibits digestive enzymes. High concentration of ethanol 40%. Inhibit digestive enzymes. Kidney. Diuresis is often noticed after alcohol intake due to inhibition of ADH secretion. Sex. It is reputed as aphrodisiac that stimulates sexual desire. Chronic alcoholism can produce impotence, testicular atrophy, gynecomastia, and infertility in both men and women. Acute ethanol poisoning. Neurological effects. Initial excitement progressing to loss of restraint. Behavioral changes. Garrulousness, slurred speech. Ataxia, unsteady gait, drowsiness, stupor, and coma. Poor control of eye movements, diplopia, and nystagmus, spontaneous horizontal nystagmus in acute overdose. Bilateral decreased vision and amblyopia due to peripheral neuritis in chronic alcoholics. Vitamin deficiencies contribute to ocular defects. Early B vitamin administration may help recovery. Allergic reactions. Rare allergic responses such as urticaria, nasal congestion, and headache, which may be severe and even fatal. 3. Cardiac effects. Cardiac dysrhythmias, atrial fibrillation, associated with binge drinking. Hypotension and tachycardia. Decreased cardiac output in individuals with pre-existing cardiac disease, coronary artery spasm, or myocardial ischemia in those with variant angina. 4. Respiratory effects. Bradypnoea, slow breathing in early stages. Tachypnoea, rapid breathing, may develop due to metabolic acidosis. 5. Breath odor. A distinct odor in the breath at all stages, not from alcohol itself, but from other beverage constituents. Odor may persist, even after sobering up. 6. Ocular effects. Ethanol is a mydriatic, causes pupil dilation. Pupils constrict in stupor and coma but dilate again near death. The McEwen sign is unreliable for diagnosing alcoholic coma. 7. Hypothermia, common in acute ethanol poisoning. Chronic poisoning, GET, gastritis, periodic diarrhea, increased incidence of oropharyngeal and esophageal cancer. Liver, fatty liver with portal hypertension, hepatitis, cirrhosis, increased incidence of hepatic carcinoma. Pancreas, acute or chronic pancreatitis, pancreatic cancer. CVS, cardiomyopathy, dysrhythmias, hypertension. CNS, polyneuropathy, cerebellar degeneration, demyelination of corpus callosum, Markia-Fava-Bignami disease, amblyopia, stroke. RS, aspiration pneumonia, alcohol-induced asthma. Endocrine, hypogonadism and feminization in males. Amenorrhea, menorrhagia and infertility in females, pseudo-Cushing syndrome. Blood, anemia, thrombocytopenia, skeletal muscle, myopathy, neuropsychiatric, memory disturbances, amnesia blackout, delusions, delirium tremens, Wernicke's encephalopathy, Korsakoff's psychosis, dementia, alcoholic hallucinosis, teratogenicity, fetal alcohol syndrome, FAS, diagnosis. Bedside test, 1 milliliter unknown solution plus 1 milliliter, acetic acid plus 1 drop H, 2 SO4 in a test tube, heat for 1 minute. A characteristic strong fruity odor is positive for ethanol due to ethyl acetate. Blood alcohol level, blood alcohol concentration, BAC, is estimated by immunoassay or gas chromatography. Osmolality, serum or plasma. Osmolality allows estimation of blood ethanol level. A blood ethanol concentration of 150 mpg% increases osmolality by 21.6 milliosmoles kg water. The following equation gives God correlation with a blood ethanol concentration. Acute poisoning treatment. A. Airway protection. Ventilatory support. DUT. Activated charcoal is not useful. DUS. Stomach wash. Not D. Thiamine 100 mg. IV. 30E. Dextrose indications. If rapidly determined bedside glucose level is less than 60 mSig/100 ml, or if rapid determination is not available, adult D, 25 grams, 50 milliliters of 50% dextrose solution intravenously, may repeat as needed. Pediatric 0.5 to 1 gram dextrose per kilogram as 25% dextrose solution or 10% dextrose solution, 2 to 4 milliliters per kilogram. Precautions: glucose administration should necessarily be preceded by 100 milligrams of thiamine IV or IM if chronic alcoholism or malnutrition is suspected, to prevent development of Wernicke's encephalopathy. F. Intravenous fluid G. A variety of drugs have been tried to hasten the elimination of ethanol or reverse its intoxicating effects, including naloxone, physostigmine, and caffeine. None of them have been proved to be truly effective. Recently, flumazenil, 3 milligrams IV, has been shown to be effective in experimental studies in reversing the respiratory depression associated with ethanol ingestion. Hemodialysis can eliminate ethanol 3 to 4 times more rapidly than liver metabolism, may be useful in patients with excessive blood levels, impaired hepatic function, and in those whose condition deteriorates in spite of maximal supportive measures. However, it is unusual for dialysis to be necessary to treat even severe ethanol intoxication. Chronic poisoning treatment. Treatment of withdrawal. It has been shown to be effective in treating alcohol withdrawal, including delirium tremens. Chlormethiazole. It is one of the most popular drugs used for alcohol withdrawal abroad and is administered in a rapidly reducing dosage over 6 to 7 days. However, it is itself associated with a strong abuse potential. Clonidine and gamma-hydroxybutyric acid have also shown promising results in the treatment of withdrawal symptoms. The former is given at a dose of 60 to 180 mg/hour IV, and the latter 50 milligrams per kilogram orally. One of the most recent entrants is tiopride, an atypical neuroleptic agent which is a selective dopamine D2 receptor antagonist. The recommended dose is 400 to 1200 mg day 6th hourly, while the maintenance dose subsequently to help abstain from alcohol should not exceed 300 mg day. Aversion therapy. The main aim in the treatment of alcoholism is to gradually wean away the patient from the clutches of ethanol once the acute manifestations of withdrawal have been taken care of. This process, referred to quite loosely as de-addiction or detoxification, should be undertaken only after admission to a hospital over a period of several days under close medical supervision. The insatiable craving for alcohol that is often present must be tackled effectively and usually requires strongly deterrent measures. One of the more successful ways is to administer a drug called disulfiram. It is a disulfide molecule, tetraethylthioram. Supportive psychopathy. Group therapy, effective in long-term management. Group therapy is effective in managing abstinence in the long term. Resocialization and mutual commitment. Groups provide opportunities for resocialization and a sense of mutual commitment. Alcoholics Anonymous, AA, self-support organization. AA is a self-support organization with no membership fees. Global presence. AA has over 53,000 groups worldwide, including in India. Informal meetings. Meetings are informal, friendly, and held weekly. Sharing experiences. Members share their experiences with addiction and recovery. Benefits. Sense of community. AA provides a sense of community and support. No cost. AA is free to join and participate. Accessible. Local AA groups can be found in telephone directories. Principles of disulfiram therapy. Ensure that the patient is off alcohol for a minimum period of 12 hours before starting therapy. The usual dose of disulfiram is 250 mg a day, which may have to be taken for an indefinite period of time. Such chronic use, unfortunately, often produces side effects like halitosis, pruritus, headache, drowsiness, impotence, peripheral neuropathies, depression, mania, psychosis, and hepatotoxicity. Methanol. Synonyms. Methyl alcohol, methyl hydroxide, monohydroxymethane, colonial spirit, Colombian spirit, pyroxylic spirit. Physical appearance. Methanol is the simplest of the primary alcohol. It is colorless, highly polar, flammable liquid. Pure methanol has a faintly sweet odor at ambient temperatures. Crude methanol has repulsive and pungent odor. It has bitter taste. Uses and sources. Antifreeze, 10 to 50%. Carburetor cleaner, 20%. Denatured spirit, 5 to 10%. Embalming fluid, 20%. Leather dyes, 30%. Paint remover varnish and shellac, 5%. Windshield washing fluid, 35 to 95%. Usual fatal dose, about 70 to 100 milliliters. Range, 15 to 250 milliliters. Serious toxicity may occur from ingestion of 0.25 milliliters per kilogram of 100% methanol, and fatalities might occur from ingestion of 0.5 milliliters per kilogram of 100% methanol. Mode of action. Absorption. Methanol is rapidly absorbed through the skin, respiratory tract, gastrointestinal tract. Peak plasma level, 30 to 60 minutes. Metabolism. In the liver, methanol is metabolized to formaldehyde and then to formic acid, which is responsible for retinol toxicity. Excretion. Metabolism is slow. Significant levels of methanol can be found in the body for up to 7 days after ingestion. Clinical features. Symptoms may be delayed for 12 to 24 hours. The earliest manifestations include vertigo, headache with stiff neck, meningismus, nausea, vomiting, abdominal pain, ocular toxicity characterized by blurred or dimmed vision and photophobia, constricted visual fields, spots before the eyes, sharply reduced visual acuity, optic atrophy, blindness, nystagmus, severe acidosis, pH 7.0 and bicarbonate, 10 mg/L are common. Onset may be delayed. 18-48 hours, especially with ethanol co-ingestion. Cardiovascular effects: tachycardia, hypotension, and hypothermia. Late-stage convulsions may lead to coma. Electrolyte imbalances: hypomagnesemia, hypokalemia, and hypophosphatemia are reported. Fanconi syndrome. Rare cases with hyperuricemia, hypophosphatemia, glycosuria, and hyperchloremic metabolic acidosis. Pancreatitis. Acute necrotizing pancreatitis may occur in severe poisoning. Cause of death: respiratory failure, often preceded by sinus bradycardia, widening pulse pressure, and severe hypotension. Long-term complications: optic neuropathy, blindness, Parkinsonism, toxic encephalopathy, and polyneuropathy. Ocular abnormalities: optic disc pallor, retinal arterial attenuation, reduced pupillary light reaction, central scotomata, and optic nerve fiber defects. Diagnosis: obtain CBC, electrolytes, urinalysis, and arterial blood gases in symptomatic patients or patients with significant exposure. Measure serum, pH, and electrolytes. High anion gap, acidosis, elevated osmolar gap, hypophosphatemia, elevated osmolol, elevated creatinine, phosphofokinase, elevated amylase C. Blood methanol level, more than 50 mg, 100 ml, indicates serious poisoning. A detectable formic acid level may be consistent with methanol poisoning. CT MRI. Symmetrical areas of necrosis in the putamen of the brain are classic finding in cases of acute lethal methanol toxicity. Treatment: stomach wash with sodium bicarbonate. Ipecac-induced emesis is not recommended because of the potential for CNS depression. Activated charcoal does not absorb significant amounts of methanol. Antidotes: ethanol is the specific antidote since it preferentially competes for the enzyme alcohol dehydrogenase and prevents the metabolism of methanol, which is then excreted unchanged in the urine. Ethanol has about 20 times the affinity for alcohol dehydrogenase compared to methanol. This competitive effect of ethanol gains more time for excretion of unchanged methanol from the body, and it also inhibits the formation of methanol metabolites that produce severe acidosis. Formic acid is metabolized to carbon dioxide and water via a folate-dependent system. Mode of administration: loading dose: 10% ethanol at 10 milliliters per kilogram IV over 30 minutes. Maintenance dose: 1.5 ml/kg/hr IV to maintain blood ethanol levels at 100, 130 ml/EG, 100 ml, 21.7, 28.2 mmol/L. Target level: safer to maintain blood ethanol concentration 130 ml/EG, 100 ml, than 100 mg, 100 ml. Preparation of 10% ethanol solution: if absolute ethanol is unavailable, use tax-free bulk ethanol with a 0.22 micron filter. Methods to prepare 10% ethanol solution: replace 50 milliliters from 1 L of 5% ethanol solution with 50 milliliters absolute ethanol. Replace 100 milliliters of 1 L dextrose 5% with 100 milliliters absolute ethanol. Add 59 milliliters absolute ethanol to 1 L of 5% ethanol solution. Add 112 milliliters absolute ethanol to 1 L of dextrose 5%. Add 59 milliliters of 95% ethanol to 1 L of 5% ethanol solution. Oral administration alternatives: 95% ethanol in fruit juice, 1 milliliter per kilogram over 30 minutes, followed by 0.17, 0.28/kg/hr as 50% ethanol in juice. Alcoholic beverage: 125 milliliters of diluted distilled spirits, gin, vodka, whiskey, rum. Repeated cautiously. Ethanol therapy. Duration: continue until methanol blood level 10 mg, 100 ml. Formate blood concentration: 1.2 mg, 100 ml. Resolution of acidosis, CNS symptoms, electrolyte abnormalities, and osmolar gap. Special considerations: patients who consumed both ethanol and methanol may have a normal acid-base profile despite high methanol levels. Determine blood ethanol level before starting therapy and adjust the dose accordingly. Alternative antidotes. Fompazole, 4-methylpyrazole, 4-MP. Advantages. No CNS depression, less monitoring required, may reduce need for dialysis. Dosing. Loading dose, 15 milligrams per kilogram. Maintenance, 10 milligrams per kilogram every 12 hours for 4 doses. After 4 doses, increase to 15 milligrams per kilogram every 12 hours if needed. Safe for up to 20 milligrams per kilogram over 5 days. Supportive therapies: sodium bicarbonate, IV, 500, 800 milliliters of 7.5% solution, slowly, to correct acidosis. Folinic acid, leucovorin, IV, 1, 2 milligrams per kilogram every 6 hours, enhances elimination of formic acid. Convulsion management, first line, benzodiazepines, diazepam, lorazepam. If seizures persist, phenobarbital. Hemodialysis, indications, acidosis or methanol levels. 2550 mE 100 ml. Effectiveness, removes methanol, formaldehyde, and formic acid. Limitations, hemoperfusion is ineffective. Peritoneal dialysis and veno-venous hemofiltration are less effective. Thank you.